All right, hi everybody. Thank you for the opportunity to present this project. As Miley said, my name is Lucas. I'm one of the clinical pharmacists at Owen Clinic, and I've been working on this project with Dr. Matthews, titled Using Clinical Natural Language Processing to Extract Morphine Milligram Equivalents from EHR Prescriptions. So as everybody knows, we're kind of in the middle of the opioid epidemic. And the CDC developed opioid prescribing guidelines, and in those guidelines they indicate the importance of calculating morphine milligram equivalents, or MME, to identify patients at increased risk. And so we know based on several studies, they've looked at the odds of overdose based on MME, and the odds of overdose were 1.3 to 1.9. For dosages between 20 and 50 MME per day, 1.9 to 4.6 for dosages of 50 to 100 MME per day, and between 2 and 8.9 for dosages above 100 MME per day compared to the lower dosages of 20 MME per day. And so the CDC made recommendations to use extra caution when increasing to greater than 50 MME per day. And so when they say use extra caution, they make suggestions like closer monitoring for efficacy and side effects, discussions about tapering and lowering the dose, and prescribing naloxone. And then they also state to avoid or carefully justify increasing the dose above 90 MME per day. So how does this tie into HIV research? We know that chronic pain is more common in people living with HIV. Compared to uninfected persons, the estimates are anywhere from 20 to 90% of people with HIV have chronic pain. And we also know that people living with HIV are more likely to receive opioids and receive higher doses compared to uninfected individuals. And some of this probably has to do with the fact that they're more likely to have substance abuse issues or mental health conditions that contributes to this. And the proportion of people living with HIV receiving opioids is estimated to be from 21 to 53%. And if you spend time in our clinic, Owen Clinic, you know this is a huge issue for our patient population with prescription opioids. So when we want to calculate MME, of course, there's tools on the individual level we can use. There's online calculators where basically you select which opioid the patient's on, put in the number of milligrams per day, and then it calculates the morphine equivalent dose. And there's also smartphone apps that can do this. The CDC has an opioid smartphone app that has the guidelines as well as a very easy to use MME calculator. However, there has to be a way to also do this on the system level, and that would include batch processing of many prescriptions to calculate MME, which could be important to improve quality of care and monitor patient safety. So this would require the analysis of the free text component of these prescriptions in the EHR to accurately calculate the daily MME. And so one option to do this would be to use natural language processing to help with automating the batch processing of these opioid prescriptions. And so for our project, we looked at a tool called CLAMP, which is a clinical language annotation, modeling, and processing. And CLAMP is a comprehensive clinical natural language processing software that enables recognition and automatic encoding of clinical information. So it's used to look at progress notes and free text portions of progress notes to identify certain elements in those, or prescriptions, for example. And the nice thing about CLAMP is that it's capable of machine learning, so you can train the software, and it's also customizable for certain applications. So the aim of our study was to evaluate the accuracy of CLAMP in reading EHR opioid prescriptions to calculate daily MME. So we used de-identified EHR opioid prescriptions extracted from an academic medical center HIV clinic in Excel for processing by CLAMP. And we used two different ways to calculate MME. The first was without CLAMP at all, just basically a rough calculation that we're terming MME 30, which basically is the dose times the number of tablets dispensed times the morphine conversion factor divided by 30. And we did this for over 24,000 prescriptions. And so the goal was just to help establish some trends that we may be seeing in opioid prescribing. The downside of this calculation is that it assumes a 30-day supply is dispensed for all prescriptions, which may not be the case. The second part of it was to use the CLAMP tool by natural language processing of the narrative text in the SIG of the prescription. So we had a single physician reviewer overread 267 prescriptions using stratified random sample by route of administration from our database of over 30,000 prescriptions to establish the reference standard for the daily MME. And then these prescriptions were compared to processing by clamp. And so when the coding rules used for clamp was when the range of the daily dose, when there was a range of daily doses, it used the higher dose. And MME was calculated using the unit dose times the number of doses per day times the conversion factor. And refills were not considered. And then the accuracy of the prediction was assessed using Lin's concordance correlation coefficient. So first, looking at some of the data from just the estimated MME-30. This is the mean MME-30 by patient Rx date presented by year. And so what we see, the trend is the highest mean MME-30, which was actually over 100, was in 2012 and 2013, and then we see a downtrend as we progress to 2017. Similarly, this is the box plot presentation of this data. You see the medians are actually much lower, but with a similar trend where higher dosages were being prescribed 2012 to 2014 with lower doses towards 2016. The 2017 data only includes the first 4 months of 2017. And then also looking at the proportion and frequencies of prescriptions that were for greater than 100 MME per day. We see in 2012 and 2013 about 20% of these opioid prescriptions were very high dose, and then more recently in 2016 and 17 a decrease to roughly 13%. And then finally, kind of a preliminary look at what might be some predictors for higher doses of opioids. This presents the adjusted odds ratios for having a prescription of greater than 100 MME. Male, female, race, CD4 count, and viral load all did not predict higher doses of opioids. The one significant predictor was age. So being over the age of 50 carried significantly higher odds of having higher dose opioid prescriptions. So then moving on to the clamp analysis, as I mentioned, we had 267 reference scripts. Of those, 26% were excluded because they were missing some element to accurately estimate the MME, which left 196 prescriptions to be evaluated by clamp. Of those, 11 were unsuccessfully processed by clamp, leaving 185 prescriptions with both reference and clamp estimates. So when we look at the correlation, the concordance between the clamp and the gold standard estimations of MME, 11 of the 185 prescriptions, or 6%, evaluated by clamp had discordant MME estimates. So the concordance between the reference standard and the clamp estimates was 0.993 over all the routes of administration. And if you look at the graphs on the bottom, you see that per the transdermal route, it was essentially 100% correlation, and then the oral route was slightly lower at 0.992. And so the discordance between the reference and the clamp estimates and those 11 prescriptions were characterized into certain patterns. And so some of the discordance that we saw was based on, one would be several of the records containing combination prescriptions of acetaminophen plus an opioid, and these were misread by clamp when the acetaminophen portion was listed first. So for example, acetaminophen and codeine, 330 milligrams, clamp read the 300 milligram dose as the opioid dose, which is incorrect. So this would result in higher clamp doses than the gold standard dose. Some records contain complicated directions with more than one instruction, and it seems like the clamp software read only the first instruction in those SIGs. And then we did notice one record did not have an output by clamp because the SIG didn't include a specific number to be taken. So it said take twice daily as needed for breakthrough pain. So some additional work that's going to be in progress or is in progress is we're going to continue to train this clamp pipeline to eliminate systematic errors. And we're going to use an expanded validation data set of 1,000 prescriptions with the help of UCSD pharmacy students to calculate the MME. So in conclusion, the clinical natural language processing application to EHR opioid scripts would help fill a gap in the available batch script processing tools. The natural language processing would also enhance individual prescription processing limitations by these clinical MME calculators that we have. And the preliminary results that we present support the use of the CLAMP pipeline to accurately calculate MME for a large number of opioid prescriptions. So some potential applications include identifying patients receiving at-risk opioid prescriptions, identifying prescribers with potentially hazardous opioid prescribing patterns, and to help contribute to the ongoing pharmacovigilance and pharmacoepidemiology of the prescription opioid use and the opioid epidemic. Limitations and cautions include that this MME calculation should be used in conjunction with Cure's prescription drug monitoring. And it should be used as or viewed as a screening tool with detailed outlier analysis to validate at-risk use and whether the clinical circumstances justify prescribing these above guideline specified risk thresholds. So that's it, and we'd like to thank our collaborators. Thank you.
Thank you, Dr. Hill. Anyone have questions?
That was great. Do you have any overdose data from the clinic?
No, but that's a good thought to look at some of this data and compare that. Yeah, but we don't have that right now.
What about like rehab entries or anything like that? Is there any?
Not specifically, no, but also good thoughts, yes.
It's coming.
Hi, Richard Garfield. Very nice presentation. Thank you very much. This is a little off subject of what you actually were trying to accomplish, but you had a really interesting finding, which was, I think it was on slide 9, you showed that over time, the median dose was fairly stable, but in 2012 and 13, I think, the peak doses were very high, and it came down. Do you think that that's reflective of more responsible prescribing so that the people that were overusing are sort of being taken out of the pool and what's left is sort of the normal or responsible prescribing?
Yeah, that's a good question. Yeah, so in 2013 was the peak of the prescription opioid deaths, essentially, and that's really the time, and that issue is what led to these CDC recommendations. So one could assume that maybe you see these high-dose opioid prescriptions kind of going, being eliminated after there was more recognition in 2013. Yeah.
Nice data, thanks.
Yeah.
Any other questions? So I have a couple. Why do you think that age over 50 was a predictor of being prescribed higher morphine milligram equivalents?
Yeah, so I think what this is kind of showing is our aging HIV population, and I would guess that these patients probably are more likely to have chronic pain issues, probably maybe more likely to have been exposed to opioids already and requiring higher dose opioids. That's probably contributing to it.
Did you look at duration of HIV infection?
No, and our analysis of predictors is kind of early and preliminary, but yeah, I think that would be an interesting thing to also look at.
Okay. And why do you think there's a trend in I guess we kind of talked about this one already. Most specifically, what struck me was the dramatic decrease in the past year of very high opioid prescriptions. What do you think is driving that?
Yeah, I think it's an awareness issue, and all of the effort that's been put into. I mean, we see it in our clinic, right? I mean, all the steps that have been put in place, it makes prescribing opioids more difficult, and it's an awareness now on a daily basis of looking out for these high-dose opioid prescriptions and making efforts to reduce those doses. I think that has something to do with it.
And along those lines, are you going to follow this up by looking to see if we're catching more illicit opioid use in people now that they don't have as much access to prescription opioid use?
That's a really good question. Something I've been thinking about actually very recently. I think one thing that the recognition of this opioid epidemic has led to is a lot more frequent U-toxes, especially over the last year, because now there's a mandate that you have to do U-toxes on people with opioid prescriptions. And so I think it'll be very interesting to look at some of that UTOX data to see some of the trends in terms of what you said, non-prescription use, as well as other substance abuse that we may not have been capturing previously.
It just seems really dramatic to me, and from a practical standpoint, knowing my patients, it's incredibly difficult to taper people who have been on high doses for like decades. So seeing that difference is somewhat concerning.
Yeah, I agree.
Okay, thank you, Dr. Hill.
Thank you.